Health Network in the University of Toronto, and Tom Pereno, a respiratory therapy clinical specialist from St. Michael's Hospital in Toronto. On behalf of the University of Toronto and Critical Care Canada Forum, it's my pleasure to welcome you to our second night of Basics of Mechanical Ventilation. Tonight we've got 3 sessions lined up, each designed as a talk for 20 minutes and followed by 10 minutes of Q&A afterwards. I think we're getting more practice with this application, and we'll be reviewing your questions that you can submit on the web app as they come in, and one of us who's not speaking will be facilitating the Q&A session after each talk. So with that, we'll get right into it. I'm first up, and here we're going to talk about basic modes of mechanical ventilation. Here's what I'm going to talk about in the next 20 minutes. So ventilators essentially just blow gas, and they do that to deliver volume and generate pressure. And to understand how different modes of mechanical ventilation work, the key thing to remember is the relationship between volume and pressure, which as we see is defined here as compliance, which is equal to the change in volume divided by the change in pressure. Ventilators blow air, and they target either volume or pressure. So the one that you set on the ventilator is the independent variable, and then the other one becomes the dependent variable. So for volume control, as a common mode of ventilation for sick patients, we set the tidal volume, as the name implies, and then airway pressures depend on the patient and their their mechanics. On the other hand, we could also put that same patient on pressure control ventilation. Here, we set the driving pressure and the time to maintain it, and then the generated tidal volume depends on the patient. All going back to our relationship here between compliance is change in volume over change in pressure. Now, if you want to talk about how different modes of ventilation work, for conventional modes, there's 3 key elements that you need to know about. That is the trigger. How does the ventilator know how to start giving a breath? The limit. How does it know how big a breath to give? And the cycle. How does it change from active inspiration to passive expiration, which is how all of these modes of ventilation work. So break this down a little bit more. The trigger can either be machine initiated, and that's essentially a clock inside a countdown clock inside the ventilator. You set a rate of 12, the machine starts counting, and if you haven't taken a breath in 5 seconds, it delivers. Or the breath can be patient initiated, and that can be through either pressure triggering or flow triggering. Pressure triggering is sort of more old-fashioned and a little less sensitive. That's where the ventilator is monitoring the pressure in the circuit, and if it senses a drop in pressure, it says, the patient must be trying to take a breath, let me help with that. Most of the time, we use a more sensitive flow triggering, where the ventilator is sending out a constant low flow through the circuit, sending out 5, getting back 5, sending out 5, getting back 5, and then suddenly only gets back 3, and it says, the patient must be taking a breath, let me help with that. So most modes of ventilation can be patient initiated, and some can be machine or patient initiated, and we'll get into that in a little bit more detail in a minute. Limits can generally be either volume or pressure, as we've said already. And then how the ventilator switches from active inspiration to passive expiration and just let the patient's elastic recall breathe out for them can depend on the mode. And it might be due to volume, it might be time related, or it can be flow related. So I'm going to walk you through a couple of 3 key modes of ventilation that you'll see commonly applied in the intensive care unit. The first, and certainly if you look worldwide, the most commonly used mode of ventilation is old-fashioned volume control, also known as assist control colloquially, but more properly is really volume cycled assist control ventilation. And you'll see why it's called that in a second. And that can be either patient or time triggered. So you set a rate, but if the patient breathes above that rate, every breath could be patient initiated, but the ventilator will never let the respiratory rate drop below the rate that you set. The limit is the volume that you program in, and it cycles after that volume has been delivered. So on this, you could have a patient completely sedated and paralyzed on volume cycle assist control, or they could be more awake and initiating some of their breaths, but every breath will be more or less the same. As soon as the ventilator is triggered, the flow valve gets turned on, flow starts and continues until the volume that you've set has been delivered. The other common mode that we use in sick patients is pressure control ventilation, which is really more properly termed pressure assist control ventilation. And just the same as volume control, it can be either patient or time triggered. So a patient could be paralyzed on this and they'll get the set rate that you delivered, or they could be triggering every breath and initiating it through their efforts. The limit here, as the name implied, is based on pressure. You dial in and tell the ventilator, raise the pressure by 10 centimeters or 15 centimeters above the baseline pressure, and keep it there for a certain amount of time. And that's what cycles the ventilator. So it says, raise it by 15 and keep it there for 0.8 of a second, and then let the patient relax and breathe out. So let's just look at a couple of ventilator waveforms here. And this, I think I'd encourage everybody who's using a ventilator to be taking advantage of the graphics that are available, because they're really, it's like having continuous pulmonary function testing going on with your patient. So the first breath here, I'm going to start on this is flow over time and pressure over time. So I'm going to start on the flow time curve initially when we're talking about volume control, because this is the independent variable that we've set. We told the ventilator, okay, turn on flow and keep delivering flow until this volume has been delivered. That results in a pressure time curve up here that looks like this. Contrast that to a pressure control breath, where we're going to start, because the independent variable here is pressure. We're going to start here, and we're telling the ventilator, okay, turn on flow until you reach this pressure, and then maintain flow to keep the pressure there for this amount of time, and then let the pressure go back and let the patient expire, breathe out. And so you can see that results in a different looking flow time tracing down here, with a higher initial peak inspiratory flow and a so-called decelerating waveform. We'll come back to the pros and cons of this in a few minutes. One final mode that I'll just mention briefly, because we're going to talk more about this tomorrow night, is pressure support ventilation. This is a very popular mode that is a spontaneous mode of ventilation, in that there is no set rate and there's no machine-initiated breaths. The only time a ventilator would start giving a patient breaths automatically when it's on pressure support would be if the patient were completely apneic and you'd trigger the backup ventilation mode. So normally pressure support is just patient initiated, so either pressure or flow triggering. It's limited by pressure in the same way as pressure control is. But here we can't, because there's no set rate, we can't set a definite inspiratory time. And so we use a little trick and use flow, inspiratory flow, to tell when the breath is ending. It takes advantage of some normal physiology. When you take a breath in, you start off with a very high flow, and then as you get closer to the end of the breath, the inspiratory flow is decreasing. And so this is the principle that pressure support uses to cycle. So if we go back to our different what different breaths, different modes look like, here we have pressure support on the end, a little dip in the pressure tracing, just indicating that this was definitely a patient-initiated breath, and then the ventilator's mission is to give flow to make the pressure tracing look something like that. And that results in usually a decelerating flow waveform like this that cycles off once this value here is about 25%. That's the default level usually of the peak inspiratory flow. Now, I make the point of telling you about this because sometimes patients can have significant resistance, not only to breathing out, but also breathing in. So if you have a patient that has high airway resistance, you may see in pressure support very long breaths because it's taking a long time to get from 100% peak inspiratory flow here down to 25%. And if you were looking very carefully at the tracing, you might even see a little blip here saying, oh, maybe that's a missed effort because the patient wanted to stop breathing out here, but the machine was still going. So we fixed this by raising the cycle off threshold and making it switch to expiration before reaching maybe at 45% of peak inspiratory flow. Not necessarily a major concern in patients with ARDS, but in patients with airway obstruction for any reason, including blocked tubes or secretions, this can be an important issue to know about. Now, again, just an example to illustrate the importance of understanding what it is that you're in control of and what it is that's resultant from the patient's mechanics. So let's take our patient who's initially on volume control, and it's 2 o'clock in the morning, is when all bad things happen, and the patient develops a pneumothorax. And this would lead to a reduction in their respiratory system compliance. So what would we expect to see? If the compliance goes down and we're in volume control, so the volume is set, that's not changing. If the compliance is down, the pressure must go up. And that's exactly what we see. Okay, and you might get a call from the bedside nurse saying, oh my God, the ventilator is high pressure alarming. And that would be alarming to anybody. And you would go and sort it out and discover that the patient had a tension pneumothorax and put a needle in their second intercostal space and hear a big hiss of air and feels like you've done some very good clinical work there. Now, let's review what would have happened if the patient were on pressure control ventilation. Patients on pressure control has a pneumothorax, their compliance goes down, pressure stays the same, so volume has to go down. And that's exactly what would happen. And the interesting thing here is that depending on how the alarms were set, it might not even alarm. There's a tendency, I think, to set pressure alarms, especially high pressure alarms, a little bit more tightly than we set a low tidal volume alarm. And but if you got a call from the nurse saying, oh, the tidal volumes have dropped a little bit, you might not even be that alarmed about it. It doesn't sound nearly as severe as, oh my God, the high pressure alarm is going off. But knowing this, you would recognize that it's exactly the same physiological process and requires the same amount of care and attention to fix it. So which is better? We get asked a lot, should we use volume control? Should we use pressure control? The truth is, either one can work well. At most modes, it's more about how you use it than which mode you choose. There are pros and cons, and you just need to understand what you're dealing with. So when you're using volume control, like it suggests, you have direct control of tidal volume, but only indirect control of the driving pressure, which may be another important factor for lung protective ventilation. If the patient is if their compliance is worsening, their driving pressure may rise inadvertently. You may not notice. On the other hand, for pressure control, you have direct control of driving pressure, but only indirect control of tidal volume. And conversely, if the patient's compliance is improving, tidal volume may increase inadvertently. There's also a factor to consider once the patients are starting to breathe spontaneously. With volume control, because you've set a predetermined inspiratory flow pattern and volume, patients might not like that. And if they have a high drive, spontaneous breathing may result in double triggering, which essentially is like a double breath, which is bad for the lung. On the other hand, with pressure control, they may be less likely to double trigger, but if they're spontaneously breathing, you've completely lost any control, direct control over tidal volume, because the patient can augment the pressure that you're pushing in. If they make negative pressure on the other side, the ventilator will just give more flow to try and maintain the positive pressure, and they can basically take as much tidal volume as they want. So there's pros and cons on either side. You just need to be aware of them. Ventilator targets. In general, and Ewan's going to talk more about this in a second, we're far away from the time where we used to say a target was a normal blood gas. Now our target is acceptable gas exchange, and we frequently accept CO2 levels that are above normal, as long as the pH is okay. We generally start with targets of tidal volumes of 6 mils per kilogram of body weight, and 6 mils per kilogram of predicted body weight, which means you have to measure their height. And there's a formula for this that's the number of inches above 5 feet times 2.3 plus 45 if you're a woman or 50 if you're a man, gives you a predicted body weight. You know, if I gain 100 kilos, my lungs don't get any bigger. In fact, maybe they get a little smaller. So height is the key factor for determining the right size of breath to give somebody. That's the first thing. And then we also want to keep driving pressure, or the distending pressure that the lung is seeing, to below 15 centimeters of water if we can, and a plateau pressure below 30. We'll talk, hear more about these in the next talk. For oxygenation, so those factors control ventilation or CO2. For oxygenation, obviously we can adjust the fraction of inspired oxygen, the FiO2, and we usually see a fairly immediate response to that. Generally, we're targeting the lowest level of FiO2 that keeps the PaO2, or the oxygen concentration in the blood, between 70 and 90 millimeters of water, targeting a saturation of 92 to 98%. And then the other thing that we set that factors in with oxygenation is PEEP, or positive end expiratory pressure. And here this is a little bit more complicated, as PEEP can affect both oxygenation and hemodynamics. As a general starting point, here's what I suggest. If you're putting somebody on the ventilator for the first time, start at PEEP of 10. That's a nice moderate level. Set the tidal volume to be 6 mils per kilogram, whether you set it directly on volume control or indirectly with pressure control, and titrate the FiO2 to achieve your target saturation. Let the patient settle into that for a few minutes, and then reassess. Is the saturation very low or the FiO2 very high? Well, then maybe you want to try going up on the PEEP a little bit. And also check the plateau pressure and the driving pressure. If they're very high, above these thresholds, try lowering the tidal volume a little bit as tolerated by pH, to see if you can get yourself within the box of safe parameters that we want to maintain. A few words about PEEP. This is not a new concept. This is the original description of ARDS from 1967 from Tom Petty and co-workers, where they found a button on this new ventilator that they had called respiratory retard, and saw huge improvements in oxygenation when they gave PEEP. There's a classic New England Journal paper from Peter Suter and Barry Fairley that again describes what is the best PEEP, trying to find the balance between lung compliance and hemodynamic effects. What do we do in real life? Shows that over the last few decades, PEEP has crept up on average in ARDS patients. The largest, most recent study is the LungSafe paper in JAMA from a few years ago. And I'll just blow this up here. Across mild, moderate, or severe ARDS, levels of PEEP that are between 7.5 and 10 on average. Just make the point that we're using PEEP often to improve oxygenation, but also to avoid a lot of atelectasis and de-recruitment which makes the available lung for ventilation smaller and more at risk of overdistension. You can make setting PEEP as complicated as you like. For most, if you were I'm just coming to use ventilators for the first time kind of person, I recommend the easiest way to do this is using a PEEP FiO2 table. There's a couple available. This one is from the original ARDS network study, the so-called lower PEEP FiO2 table, which puts people on PEEPs of 8 to 10 to 14 generally. It sometimes gets up into high PEEP if you're on very high FiO2. Some patients may benefit from a higher PEEP FiO2 table. This is from the lung open ventilation study and others like it, showing that when you're at these moderate FiO2 levels of 0.5 to 0.6, you're up into the 18 to 20 centimeters of water range already. And in patients with more severe ARDS, moderate to severe ARDS, when you pull a lot of data together, there is a bit of a signal for using higher PEEP rather than lower. But people are heterogeneous, and it's important to recognize that some people are going to respond to higher PEEP and some aren't. Often, the ones that respond to higher PEEP have a key factor here. This is a nice illustration from a paper from Luciano Gattinoni almost 15 years ago now, where they just took ARDS patients to the CT scanner and looked at them at 5 and 45 centimeters of water PEEP to see how recruitable they were. Here's a typical recruiter. Note that they had a lot of white atelectatic consolidated lung in the dependent regions at lower PEEP that substantially was recruited at higher PEEP. Here's a non-recruiter. First thing to notice is that their baseline CT scan looks kind of like the finishing CT scan of our previous patient. The message here is that you can't recruit lung that's already aerated. You can only overdistend it. And that's what happens here. You overdistend lung and look at the heart. Absolutely squished. So the right heart, which is not what we saw so much in the patient where there was a lot of recruitment. So important to think about both how much lung am I going to be able to recruit with higher PEEP, and what are the hemodynamic effects that my right ventricle is going to have to put up with if I'm only overdistending and not actually achieving my goals here. And this study just shows you that if you want to use higher PEEP in patients who are more recruitable, the best way to do that is with a PEEP FiO2 table. I'm going to skip a couple of slides just in the sake of time and jump my take-home points here. Tried to show you that ventilators target either pressure or volume. The other is then the dependent variable depending on patient mechanics. Remember that pressure and volume relationship that's governed by compliance. Apply standard principles of lung protection and target acceptable gas exchange, not necessarily normal. And setting PEEP can be as complicated as you want to make it. And with that, I'll be happy to stop and take questions.
Great. Thank you very much, Neil. That was a great introduction to modes of mechanical ventilation. We've got a number of interesting questions that have come in from the audience. So the first one is just an important question about tidal volume. When we talk about 6 mils per kilo, are we setting it based on ideal body weight or lean body weight, or what body weight do we use to determine 6 mils per kilo?
Great. So just to reemphasize that point, we want to use that based on a height-based calculation for body weight. So get out the tape measure. If you don't have a tape measure, you can guesstimate, but if it's better to actually have an accurate measure of the patient's height. And then there's a standard formula that's available either in centimeters or in inches. I keep the one in inches in my head. So it's 2.3 times the height in inches above 5 feet. So if somebody's 5'10", it's 23 plus 45 if you're a woman, or 50 if you're a man. And that's your predicted body weight. I'd like to say it's predicted, not ideal, because it makes me feel fat every time I calculate it on myself.
So there's another question here. Is there any significant difference in square versus decelerating flow, inspiratory pattern, volume control? Last night we learned that the alveoli don't see the resistive pressure. So does it mean there's no benefit with a decelerating pattern?
There's probably not a lot of difference in a patient who's sedated and paralyzed, and purely thinking of the from the alveoli's standpoint. You're right; they probably don't care whether it's square wave or decelerating waveform. If you think about the whole patient, though, if the patient's breathing spontaneously and initiating breaths, they're less likely to have flow starvation, especially in the setting of the larger respiratory efforts, if you have them on a decelerating waveform.
That's very helpful. Here's another interesting question. Is there an efficient way of reducing double breaths during volume controlled ventilation? So you're setting them in volume control, but they're double triggering a lot. Is there a way to address that?
So it's very tricky. So one thing would be to, as we just said, see if you can turn up the inspiratory flow rate as much as possible, and have a look at the patient's X-ray and understand why their effort is so high. Do they have a lot of derecruitment and hypoxemia? In that case, PEEP can sometimes blunt their respiratory drive. You might say, well, I'm willing to accept 7 mils per kilogram. You might try a slightly higher tidal volume to see if they can, 7 mils per kilogram would be better than double triggering every second breath at 5 or 6 mils per kilogram. And if none of those things are effective, then you can switch to pressure control, which will likely result in higher tidal volumes, or you can sedate and plus or minus paralysis to take over. And how and when you decide to do that will be dependent on the severity of the patient and how often this is happening.
And Neil, they probably should check to see if the patient was triggering the first breath as well, because it could be a different mechanism of double breath. For sure.
So yeah, sorry, that's a great point. So you said double triggering, and I took you at face value, but it might actually be reverse triggering, where we see the mechanical breath is initiated by the machine, and that triggers a reflex in the patient where a second breath can happen, and that can sometimes result in a double trigger, or sometimes can just be a little deflection that sort of looks like a mixed effort. And that we often see in patients that are just not ones that are hugely deeply sedated, but often in the transition as they're coming out of sedation and they start to have some intrinsic rate. That's where we often see this reverse triggering.
Neil, why do you go up on FiO2 when you increase PEEP based on the PEEP FiO2 table? Can you sort of help us understand how a PEEP FiO2 table works?
Yeah, I think it's just the immediate risk. The patient's desaturating. I need to fix something right now. What am I going to do? I'm going to turn up the FiO2. It's going to have an immediate effect, and that's sort of often an indicator that of the severity of the illness. And if the patient's reading their textbook and the PEEP FiO2 table is working properly, you're up at a high FiO2. You turn up the PEEP, you recruit lungs, and you come. And that allows you to move leftwards on the PEEP FiO2 table. So I think that PEEP FiO2 tables are a good starting place, and they provide higher PEEP for patients who need higher levels of oxygen, which is often because of derecruitment that might respond to PEEP. But the important caveat is that not every patient will respond like they are. And if you put the PEEP up and the patient's oxygen doesn't get better, then you need to consider, oh, maybe this patient's not a high PEEP responder. Maybe I'm just over distending. I should try and lower PEEP again.
Lots of questions coming in about COVID-19 management. Here's a question. What would be the role of PEEP in COVID patients with preserved compliance, i.e. the so-called L phenotype? What should be the range of PEEP setting in those patients?
Yeah, so those patients stereotypically have relatively normal X-rays, and not a lot, some ground glass opacity on CT scan, not a lot of consolidation and low compliance. So they're likely not to be great recruiters because their lung is not hugely de-recruited to start off with. And so for that reason, I would usually start off with a relatively lower PEEP in those patients. And I would go higher on the FiO2. That's not to say though that if they're on 80 or 90% oxygen on PEEP of 10, patients don't read textbooks all the time. I would try an increase in their PEEP level to see what happened. And it may, because in some of these patients we have seen, we've had patients being transferred in. I think people were reading you have to use high PEEP in everybody tweets about this. We were frequently seeing people coming in with PEEP of 16, 18, which seemed higher than their x-rays might suggest. So we'd frequently try turning down their PEEP. And sometimes that worked, but sometimes a little bit to our surprise, their hypoxemia got worse. And that may be that we're using PEEP in that regard to raise pressure control, giving a relatively small driving pressure, and then I just watch the change in tidal volume with every decrease in PEEP, and that tells me where the compliance is changing. And you could use the best compliance PEEP. You could also say, well, I'm going to go from PEEP of 8, and I'm going to put the PEEP up to 16, and then I'm going to see what happens to my oxygenation. And work that we've done together, as you know, shows that that's a good predictor. If you put the PEEP up and the PO2 goes up, there's a significant association with improvements in mortality. Whereas if you put the PEEP up and the PO2 gets lower, that's bad for the patient, and so you should back off from that. And then finally, we have a new recruitment to inflation index that Tom has helped develop with Laurent's team at St. Mike's, and there's handy ways to. I don't have time to go through that in detail here. I don't think that's for the basics of mechanical ventilation course, but it's on the RT Maven website if you want to see videos of how to do that.
Terrific, thanks, Neil. So I think for the sake of time, there's a lot of great questions here, but we're going to have to move on to the next talk. So I will share my screen. And start the presentation. All right, so I've been tasked with addressing the question of risks and complications of mechanical ventilation. I just would mention I have a couple of disclosures to make about research support from Tim Pell and from Getinga, as well as some personal fees from Getinga, which is a ventilator company. So all of our discussion about mechanical ventilation is occurring in the context of a worldwide pandemic of respiratory failure from an acute viral infection. And in fact, the whole business of modern mechanical ventilation was born in the context of an epidemic of viral infection resulting in neuromuscular respiratory failure, poliomyelitis. And the famous story of how positive pressure ventilation was really born in Copenhagen in 1951 is a fascinating story. But the important point I want to emphasize here is that before they initiated routine positive pressure ventilation for patients with respiratory failure from polio, they had about an 87% mortality rate. And in the months after initiating routine positive pressure ventilation, that mortality rate fell dramatically to 40%. So it's worth noting that if it wasn't for mechanical ventilation, I suspect the case fatality rate from COVID-19 would be higher than it is. And so what we're talking about is so important. There's no question that ventilation saves lives. But like anything we do in medicine, along with the good comes potential harm. And so this talk is basically designed to introduce you to the issue of risks and complications attached to mechanical ventilation. So when you're at the bedside, assessing the patient and thinking about the ventilator settings that you're applying, we want you to take into consideration several important potential complications. First of all, the hemodynamic effects, and in particular, the effect on the right ventricle. Secondly, the potential to cause lung injury by the way that you're setting the ventilator. And then thirdly, the potential to injure the diaphragm by virtue of how the ventilator is being applied. So I'm just going to briefly overview these things over the next 15 to 20 minutes and hopefully give you a kind of framework for thinking about them at the bedside. So how to think about the hemodynamic effects of positive pressure ventilation. Well, when you inflate the lungs with positive pressure, you pressurize the pleural space, the space around the lung. And that pressure is in turn transmitted through to the heart and vascular structures. So positive pressure is applied not only in the lung, but on both the right and left ventricle. And this impacts various aspects of right and left ventricular function, as well as having an impact on venous return. And so it's easy to imagine that these pressure swings could have potentially important impact on cardiac function. So I'm just going to briefly review the impact of positive pressure on right and left ventricular function separately. So in terms of thinking about the impact of positive pressure applied to the thorax on right ventricular function, the first obvious thing is that it's going to reduce the gradient for venous return. You're increasing the pressure inside the thorax. The blood flow into the thorax is driven by the pressure in the abdomen minus the pressure in the thorax. And so you're obviously potentially reducing venous return. And in a critically ill patient who may already be somewhat intravascular volume deplete, you can have substantial drops in venous return that could cause serious hemodynamic impairment. Secondly, you're directly pressurizing the right ventricle itself. So that again reduces the gradient for ventricular, right atrial and right ventricular filling. You're also applying pressure within the lung, and that's transmitted through to the pulmonary vasculature, which has complex effects on pulmonary vascular resistance. But I think the important idea here is that the more pressure you apply in the lung, the harder it is for the right ventricle to drive blood flow through to the left side of the heart. And so the key idea that we have to be careful of is that we try to avoid excess airway pressures in order to protect the right ventricle from developing pressure and volume overload. And a key variable to monitor when you're applying mechanical ventilation, and you're going to hear this over and over again throughout this talk, is the airway plateau pressure. So the plateau pressure is the pressure I'll show you on the waveform momentarily, but it's essentially the upper pressure applied to the lung during tidal inflation. And as you can see, the risk of both mortality and acute cor pulmonale, that's the black bars here, progressively increases at higher airway plateau pressures. So the plateau pressure needs to be borne in mind in order to avoid injuring the right ventricle and causing acute cor pulmonale. The other important thing, though, is that there's a certain sweet spot that you want to target. So if airway pressures are too low and there's a lot of lung de-recruitment, then that also increases pulmonary vascular resistance. So there's probably a happy medium of airway pressure to apply to the lung that minimizes pulmonary vascular resistance. And this actually unloads the RV and supports hemodynamic function. But as the airway pressures continue to rise, you'll have overinflation and that'll increase pulmonary vascular resistance. So finding the exact sweet spot is always uncertain. Again, typically starting at a PEEP between 5 to 10 is probably going to be an optimum spot for minimizing pulmonary vascular resistance. The left ventricle, on the other hand, actually likes the application of positive intrathoracic pressure. And this is because its main job is to drive blood flow out of the left ventricle and into the systemic circulation. And a major determinant of how much work it has to do is the pressure gradient that develops across the myocardial wall. That is the pressure inside the ventricle minus the pressure outside the ventricle. So if you're making vigorous negative inspiratory efforts, you're actually increasing afterload and increasing myocardial oxygen consumption. So by applying positive pressure, you reduce the pressure around the ventricle and support and assist its function. The important point to bear in mind is that as you start to reduce positive pressure during the weaning process, the left ventricle has to take on more and more work. And so probably the most common reason for patients who have difficult weaning is impaired left ventricular function from an increase in afterload as you reduce positive pressure. So this mechanism, hemodynamic effect, needs to be borne in mind. All right, so let's move from the heart to the lung. And within about 20 years of the institution of positive pressure ventilation, it was recognized that the mechanical ventilator can do serious harm to the lung. And this was demonstrated in a classic experiment in the 1970s, where they took rat lungs and subjected them to different levels of pressure. So you have the lung on the left subjected to pressure swing from 0 to 14 centimeters of water. The lung in the middle subjected to pressure between 14 and 45 centimeters of water. And then the lung on the right, which you can see is qualitatively different, a lot of hemorrhagic necrosis manifest, and it was subjected to pressure swings from 0 to 45. So it's recognized that the application of these very large pressures could significantly damage the lung, and that's given rise to the whole modern concept of the need for lung protective ventilation. So how does ventilator-induced lung injury work? Well, very simply, it's basically an overstretch of the lung. And so when you apply excess pressure to the lung, you're overstretching or overdistending it, and that activates an inflammatory response within the alveolar parenchyma or pulmonary parenchyma, and leads to an inflammatory response within the lung that can then what we call decompartmentalize and spread throughout the body and actually cause multi-organ failure. So, but probably the most important mechanism of ventilator-induced lung injury is this idea of overstretch, or what we call volutrauma. Another potential mechanism is not ventilating the patient at lung volumes that are too low. This is where a lot of atelectasis is allowed to develop. And as a consequence of this, the lung parenchyma becomes very irregular. The distribution of stress within the lung becomes very heterogeneous, with some areas being subjected to very high stresses and other areas relatively low stresses. This also means that with each tidal breath, parts of the lung will be opening and closing, and therefore subjected to shear forces. And there's evidence that ventilation at excessively low lung volumes also leads to ventilator-induced lung injury. So we want to avoid that mechanism of injury by applying a sufficient amount of PEEP. And so this really becomes an important challenge. How do you set PEEP to optimize cardiac function, and how do you set PEEP to minimize ventilator-induced lung injury? And much of that is really what Neil spent time explaining in the last talk. So conceptually, basically, lung protective ventilation involves reducing the amount that we're stretching the lung to the minimum level necessary, while also maintaining adequate end expiratory lung volume with some PEEP in order to avoid lung injury at low lung volumes. So how do we monitor this? Well, a very important maneuver that everyone managing a ventilator needs to be able to do is the plateau pressure. And the plateau pressure, these tracings here, we've got flow at the top and we've got airway pressure at the bottom. And if you look at this segment here, we've applied an inspiratory pause, an end inspiratory pause. So at the end of inspiratory flow, the ventilator does not allow expiratory flow to develop, and so all the pressure within the lung is maintained, and this develops a stable plateau that we can measure the plateau pressure. And so the difference between plateau pressure here and the total PEEP, or end expiratory pressure, is the elastic pressure applied to the lung with each breath. We refer to this as the driving pressure. And this is probably the most important determinant of how much lung injury develops. So when we're setting the ventilator, we want to set the tidal volume to maintain relatively low tidal volume, and importantly, to avoid excessive plateau airway pressures. But the story gets a little more complicated, because while the patient's passively ventilated, all of the pressure applied to the lung is delivered by the ventilator. But once the patient resumes spontaneous breathing, the pressure being applied to the lung is not merely from the ventilator, but also from the patient. I'm trying to symbolize here this with the red diaphragm and the arrow moving in encephalite direction, or in caudal direction. So essentially now we're pressuring the lung both from the inside, that is the airway pressure, and from the outside, a more negative pleural pressure. And the net effect is to increase the transpulmonary pressure. So you can have ventilator-induced lung injury not just from how you set the ventilator, but also from how the patient behaves. And this is referred to as patient self-inflicted lung injury. And there's been lots of discussion as to the potential role of patient self-inflicted lung injury in patients with COVID-19. The good news is it's still relatively easy to monitor for the risk of patient self-inflicted lung injury in a ventilated patient. So here we've got a patient who's breathing in pressure support mode. You have inspiratory flow here, and you can see we've applied an end inspiratory pause. So the end inspiratory pressure here actually increases during the pause. And this is because the pressure we see in the lung now is not only that delivered by the ventilator, this airway pressure increase here, but also that resulting from the patient's own efforts. But in many patients, we can still get a relatively reliable driving pressure measurement that allows us to assess just how much the lung is being distended. Easy methods for detecting vigorous inspiratory efforts are two different pressure measurements. So if you maintain an end expiratory hold in a spontaneously breathing patient, you'll see that here there's an expiratory hold, so no flow develops. And all of the patient's effort now becomes apparent because a negative pressure swing develops. And so we use this measurement, referred to as POCC, to detect large inspiratory efforts. And then this pressure here, P01, is the pressure developing in the airway during the first 100 milliseconds. And many ventilators will actually provide this on an automated basis. And so this is an easy way to detect whether patients have large inspiratory efforts. So a POCC above 15 or a P01 above 3.5 would be concerning for excess inspiratory effort. So what does lung protective ventilation look like? Just to summarize briefly and simply, we want to aim to maintain tidal volumes in the 6 to 8 mils per kilo predicted body weight range. We want to avoid excess driving pressures, and we want to avoid excess plateau pressures. The plateau pressure is the pressure during the end inspiratory occlusion. And we also want to avoid excessive respiratory efforts. And the general spirit of this approach is that we want to be gentle on the lung. We want to ventilate the lung with the minimum amount of pressure and volume required to achieve acceptable gas exchange. Another important mechanism that needs to be borne in mind when you're setting the ventilator is the issue of ventilator-induced diaphragm dysfunction. I'll just address this very briefly before we wrap up. So the diaphragm and respiratory muscles are a ventilator. They're the respiratory pump. They are what determines how much air flows in and out of the lungs with each breath. And diaphragm function in particular, as the primary muscle of inspiration, is crucial for maintaining ventilation in the face of an increased respiratory load. And so whether you develop respiratory failure is basically a function of the demand placed on the system, shown here on the left, versus the capabilities of that system, as largely defined by the strength and endurance of the respiratory muscles. And it turns out, and if you have diaphragm dysfunction, you're much more likely to have difficulties getting off the ventilator. And it turns out that many patients on mechanical ventilation develop significant diaphragm weakness. And this has been nicely demonstrated in many studies. This is perhaps the classic image from a paper in the New England Journal over 10 years ago, showing the development of rapid onset atrophy of the diaphragm over a period of 20 to 50 hours because in brain dead organ donors. So the cases here shown on the left are brain dead organ donors who've been declared brain dead for anywhere between 18 to 69 hours. And the controls are subjects undergoing thoracic surgery for just 3 or 4 hours. And you can see that the cross-sectional area of these muscle myofibers is dramatically smaller in the cases. And as a consequence of that, we have to try to maintain diaphragm activity. This atrophy seems to develop because of inactivity of the muscle, and consequently putting someone on a ventilator and taking over all of their work of breathing results in a rapid disuse atrophy. On the other hand, you can also get significant diaphragm injury from excess loading on the muscle. So if you subject animals or humans to very high levels of inspiratory effort, you can change the nice normal architecture of the muscle shown here on the left into this deranged, damaged ultrastructural appearance with inflammatory infiltration. And so excess loading on the muscle can also be an important cause of diaphragm injury and weakness. And diaphragm atrophy during mechanical ventilation appears to be quite common. We found that about 45% of patients develop significant decreases in diaphragm thickness during mechanical ventilation, as shown here in this figure. So this is a very common problem that's associated with delayed liberation from mechanical ventilation. We try to prevent by keeping the patient breathing at the earliest possible opportunity. So again, how do we determine whether the patient's breathing? Well, we went through these maneuvers earlier, but you can use the P01 or the POCC to determine whether or not the patient's making inspiratory efforts. So if you maintain an expiratory hold and the negative pressure deflection develops during the occlusion, then you can see that the patient's making inspiratory efforts. Or if the, and this is reassuring that the patient's at somewhat lower risk of developing diaphragm atrophy. So the general idea of diaphragm-protective ventilation is that we want to try and minimize the duration of passive ventilation, resume spontaneous breathing on the ventilator at the earliest opportunity, provided it's safe for the lung. And we think that keeping the patient's breathing at a resting effort level might accelerate liberation from the ventilator, although I want to emphasize that the evidence base for diaphragm-protective ventilation is not nearly as well developed as it is for lung-protective ventilation. And lung protection really remains a priority because this has been proven to reduce mortality in patients with ARDS, such as COVID-19. So just to summarize, we have seen the hemodynamic effects of positive pressure ventilation and the risks of ventilator-induced lung injury and ventilator-induced diaphragm dysfunction. And we want to keep these mechanisms in mind when we're applying the ventilator at the bedside. And the key, I think, is to regularly monitor plateau area pressure and P01 or POCC and the total PEEP in order to stay on top of the plateau pressure, the driving pressure, and the patient's level of inspiratory effort. And taking these things together will help you to ensure that the heart is not adversely affected and that the lung and the diaphragm are protected. Great, thank you very much.
Thank you, Ewan. That was excellent. So we do have some questions. I've tried to reply to a couple, just asking to define some of the acronyms, but just in case anyone else was asking, one was for PAW, so that was the driving pressure during an inspiratory pause, I believe you were showing during the POC maneuver. And then the POCC also, it was an occlusion pressure. So I've already answered the questions, but just to clarify that for anyone else who may wonder what those acronyms were. So one question is, can you just repeat the effect of positive pressure mechanical ventilation on the left ventricle? I think you focused a lot on the right, but you may have mentioned the left very briefly.
Sure. So the general framework is that whereas the right ventricle doesn't like positive pressure ventilation unless there's a lot of lung de-recruitment, the left ventricle loves positive pressure ventilation. And this is because applying pressure around the left ventricle reduces the amount of work the muscle has to do to contract and squeeze blood out of the left ventricle. So the afterload on the left ventricle is the transmural is partly related to the transmural pressure gradient, the pressure inside the ventricle minus the pressure outside the ventricle. So when you raise the intrathoracic pressure and you raise the pleural pressure, then you decrease the pressure gradient across the left ventricle and you reduce its afterload. So in general, the left ventricle likes positive pressure. This becomes a big problem when we are trying to wean the patient off the ventilator, and many patients will develop weaning-induced pulmonary edema because the load on the left ventricle actually starts to go up. And so we are trying to manage afterload and diurese the patient to try and optimize cardiac function in order to help get them off the ventilator.
Thank you. So here's another question. Why do we worry about plateau pressure and driving pressure, but not peak airway pressure? Now, I think maybe Laurent discussed this yesterday. Which is the highest pressure the lung will see?
That's a really thoughtful and important question. I'm glad we're addressing that.
Yeah.
So the peak pressure is actually a pressure that the lung parenchyma does not see. The alveoli do not see the peak pressure, because the peak pressure is the pressure that develops as a consequence of both airway resistance and pulmonary parenchymal compliance. So it's really only the plateau pressure and the driving pressure that are actually reflecting how much the pulmonary parenchyma are being stressed. And this is why we're emphasizing those pressures rather than peak airway pressure.
Okay. Another related question, why is the plateau less than 30 the magic number? Your earlier slides show an increased mortality when plateau was above 25. Is there a linear response? Should we target the lowest plateau possible?
Again, that's a very, very thoughtful question. And the answer is absolutely yes. So the original idea of emphasizing a plateau pressure less than 30 is that if you inflate the respiratory system of a healthy volunteer to plateau pressure, to total lung capacity with a positive pressure ventilator, the plateau pressure will be about 30 centimeters of water in a healthy volunteer. So really the idea with
to minimize the stretch applied to the lung. However, there's a lot of evidence that's accumulated over several years indicating that patients probably have a better survival the lower the plateau pressure is, and that's true for cardiac function, and it's also true for the issue of lung protective ventilation. So I would agree with the approach of trying to maintain the lowest plateau pressure reasonably possible, and especially the lowest driving pressure reasonably possible.
Right. So can you comment on the short and long-term implications of PEEP on diaphragm function or dysfunction?
Yeah, so this is an interesting question. We really don't know what are the long-term implications of PEEP, or the long-term implications of PEEP on diaphragm dysfunction. In the short term, increasing PEEP will impair diaphragm function because you're positioning the muscle at a shorter length at the onset of the breath. You're impairing its length-tension relationship. But that can be useful because it's a way of actually attenuating the level of inspiratory effort that the patient's making, which may be both lung and diaphragm protective potentially. There is some evidence that the use of high PEEP leads to rapid decrease in the length of the muscle, so that may be a mechanism of diaphragm injury. But we need a lot more research to understand how setting PEEP ultimately impacts diaphragm function.
Another question related to diaphragm function. Are multiple SPTs associated with diaphragm dysfunction?
Yeah, so patients with diaphragm dysfunction are much more likely to develop difficult or prolonged weaning. So we have a basic classification system for weaning, which we'll talk about more on Friday. But basically, you can divide patients into simple weaning, where they're past their first SPT and are extubated, difficult weaning, where they require up to a week to get off the ventilator during the weaning phase, and then prolonged weaning, which is more than 1 week. And so if you have diaphragm weakness, you're much more likely to require multiple SPTs and to require a very prolonged time in the weaning phase of mechanical ventilation. It's harder for you to get off the ventilator. So this is why we care a lot about trying to maximize and optimize diaphragm function.
Right. Now, what about such high PEEP used in patients, in these patients going to affect the intracranial pressure with someone with CNS compromise? Are we worried about PEEP and intracranial pressure?
This is a very thoughtful question. So there's some concern that when someone has raised ICP, when you raise the intrathoracic pressure, you prevent the flow of venous blood out of the cranium and back into the thorax. And so often we try and minimize the amount of PEEP that is applied in patients with raised intracranial pressure. And probably the other important thing to bear in mind is that patients with raised intracranial pressure, because of the loss of cerebrovascular regulation, autoregulation, they do not tolerate changes in arterial pressure at all. So if you're setting PEEP in a way that lowers arterial pressure or reduces cardiac output, you're significantly increasing the risk of cerebral ischemia. So in general, we want to minimize the PEEP applied in a patient with raised intracranial pressure. Some of those patients will develop ARDS and will require some level of PEEP to maintain oxygenation, but it becomes a careful balance.
How frequently does one need to monitor plateau pressure and indices of patient effort? So maybe something like P0.1 or POC.
Great question. I think they should be performed routinely as part of your regular assessment of the ventilated patient. In our ICU, we monitor all of these measurements every 4 hours as often as we can. I might emphasize that in the case of COVID-19 patients, because we're trying to minimize going into the room, we've cut back on that a little bit and probably making those particular measurements of plateau pressure, POC and P.1, maybe more like every 12 hours. But the point is to do it regularly enough that you can detect significant changes in lung mechanics and respiratory effort. And you will see when you start doing it that as you adjust the ventilator, these pressures reflect the impact of your ventilator settings. And so they become very useful to understand how the lung and the diaphragm are being affected by your ventilator settings. So I encourage you to do it as regularly as you can.
Probably we have time for maybe 1 or 2 more questions. Does higher plateau result in the same negative hemodynamic effects as higher PEEP?
Yeah, that's a great question. I think, to be honest with you, probably the most important pressure with respect to hemodynamics is the mean airway pressure. And so you'll increase your mean airway pressure at a higher plateau pressure, and you'll increase your mean airway pressure at a higher PEEP. So they both have similar kinds of effects on hemodynamics. So if you're maintaining a low PEEP, but you have a very high plateau pressure, then absolutely you're putting the right ventricle at risk of increased afterload and increased work. So both PEEP and plateau pressure need to be monitored carefully.
Even fair to say probably that just because of the relative amount of inspiratory to expiratory time, that the PEEP has that usually has a bigger effect relative to plateau. But and also this is why APRV, if you're using very high plateau, very high P highs for extended periods of time, can have a significant hemodynamic effect because you've inverted that relationship and made plateau pressure more important.
Yeah, that's a great point.
And just one last final thing, Ewan, there's a few questions asking about the POC maneuver. So maybe you can plug the paper by Michel Bertoni and yourself and maybe the online calculator.
Yeah, absolutely. So super easy to do. It's I'm just going to show the slide here. Can I share my screen again? Just very quickly, I'll just show the slide to explain the maneuver. So it's you apply an expiratory hold during any mode of mechanical ventilation. It doesn't matter whether it's a controlled mode or a partial assist mode. If the ventilator allows you to do it, you apply this expiratory hold. And during the expiratory hold, if the patient is making respiratory efforts, then this negative pressure deflection will develop, and that reflects the effect of the respiratory muscles on airway pressure against the closed valve. And so this allows you to quantify indirectly the patient's inspiratory effort and also estimate how much pressure the patient's breathing muscles are applying to the lungs. So there's a very nice paper by Michele Bertoni and colleagues that validate this measurement and explain how to use it. And Tom Pereno here has a beautiful website, first of all, that everyone should consult, rtmaven.com, that has a lot of helpful tools for assessing respiratory mechanics and makes complicated issues really clear and easy to understand. And you can use a calculator on his website to estimate PMUS, which is the patient's respiratory effort, and the transpulmonary driving pressure, which is the pressure applied to the lung during spontaneous breathing.
Great, thank you. I think we're done.
Great.
There were many, many questions. I thank everyone for the questions, but we do have to think of time.
Okay, Tom, so over to you for our last talk of the session.
Okay, great. Let me just share my screen here. Okay, so I get to talk about how I set the ventilator. And luckily, Neil ran through a lot of the information regarding the different types of modes that I will discuss quickly. So I will, first off, my disclosures, I have speaker fees and consulting for a few companies, but nothing related to this talk. And just to, again, remind you some of the settings that Neil mentioned. So FiO2 is just the fraction of oxygen that's, of course, that we're delivering to the patient. PEEP is positive end expiratory pressure. Of course, the trigger sensitivity is simply the criteria used by the ventilator to determine patient effort. Now, there are two main conventional modes of ventilation: volume assist control and pressure assist control. And the reason why I choose one over the other is really because of my actual love of respiratory system mechanics. So when you have these modes being delivered, you know that both modes will allow you to see tidal volume in real time being delivered by the ventilator. That's not a problem. And of course, we have PEEP, and if we do an expiratory pause, we have PEEP total, which is our total amount of PEEP, including intrinsic PEEP. And we have peak airway pressure. So we have peak airway pressure here and peak airway pressure here. But where it gets a little complicated, again, for getting compliance and airway resistance, let's just talk about airway resistance and flow. So as you know, volume control, if you're using constant flow, you have a set flow rate that does not change. Of course, in pressure control, you have pressure that does not change. Now with this flow, you can set a value. And for this example, I'm going to give 60 liters per minute of flow. And of course, in the resistance calculation, you need liters per second. So all you need to do to convert it is to divide by 60. Well, of course, that gives you 1 liter per second to plug into this calculation. So that's very helpful. So now we have something that can be plugged into there, but the one thing I haven't mentioned yet, of course, is plateau pressure. And one of the nice things and utilities about volume assist control is that it actually has a setting called inspiratory pause that is available on every modern ventilator. You can set an inspiratory pause, which will then give you a period of no flow. And when you have no flow, you eliminate resistance. And of course, when you eliminate resistance, you are left with a plateau pressure that represents the pressure, again, descending the lung with no flow. So it's the elastic pressure. And of course, you have PEEP. Therefore, plateau minus PEEP, you actually have driving pressure in real time, breath by breath. So as Ewan mentioned, doing plateau pressures, every 12 hours, you can set up your ventilator to give you a plateau pressure every single breath. And this is my preferred method. Now, the issue with flow with pressure assist control, of course, is that flow is changing over time. So what exactly do you plug into the calculator? And many ventilators will offer you a value of airway resistance. It is estimated because it has to do some calculations to estimate what the resistance might be. But of course, setting a constant flow, you can calculate it in real time. Now, plateau, there's no inspiratory pause when using pressure assist controls. You would have to do a manual pause if you're using this mode. Because the other option would be to extend your I time very long until you have zero flow. And of course, that can be problematic with your expiratory time. Having said that, you have a flat pressure here and a PEEP here. Is that driving pressure? The question really comes down to whether or not your flow reaches zero. So the farther away you are from zero flow, the less likely that this pressure represents your driving pressure. But in a passive patient, you can be certain that if the flow does not reach zero, your driving pressure is probably lower than what you've set if your patient is passive. So having known that I love respiratory system mechanics, my choice of mode to start off a patient in the acute phase is volume assist control. Now I will go through setting up each mode, but just talk about volume assist control. Many of this stuff Neil already mentioned. So we have respirations per minute, 6 to 8 mils per kilogram ideal body weight. determines the time, and then that's where we would set the tidal volume. Flow determines the time which it takes to deliver the volume. So again, this is the criteria. The cycling criteria is basically once the volume is delivered. However, the cycling criteria can be altered by setting the inspiratory pause. So as it was mentioned, flow and volume, this is typically the criteria. Once you get to this volume, which is based on how fast the flow is delivered, it usually will cycle off the breath, but you have the ability to actually lengthen this time. So initial settings, as has been mentioned already, setting 6 to 8 mils per kilogram of predicted body weight. Typically, if someone is in hypoxemic respiratory failure or they've developed ARDS, we will start lower at 6. Having said that, I do recommend absolutely measuring their height, but if this is an acute thing that's going on right now, someone just getting intubated, nobody has a tape measure around, a decent average I have found that's been pretty consistent. If you get around 450 for, again, if the male is of average height, 450 for a male, 350 for a female, you'll be pretty close to 6 mLs per kilogram, but I do highly recommend measuring it, getting it accurate. Many people will create tables that it's like a lookup table of you have their height and it tells you what 4, 6, and 8 mils per kilos are. There's many of these tables online that you can find, and of course there's calculators online as well. Respiratory frequency should be considerate of any pre-existing hypercarbia or acidosis that the patient may have been fighting with their own respiratory rate prior to intubating them. So generally, I will base it on that. The flow that I would set on volume assist control would be between 50 and 60 liters per minute of flow. With smaller tidal volumes, I may be more apt to choose a slower flow rate only because the resulting inspiratory time is very short, but it's short. But because it's short, it allows you to set this pause, which then makes the mode much more useful, again, as a measure of plateau pressure, driving pressure, and because you have constant flow, airway resistance. PEEP typically is set between 5 and 10 centimeters of water. I usually joke that 10 is the new 5. When you have someone that's in respiratory failure due to hypoxemic reasons, if they have, again, bilateral infiltrates on chest x-ray, you probably want to start with a more moderate amount of PEEP, like 10 centimeters of water. Now, FiO2 is tricky. Many people, because they pre-oxygenate patients on 100%, they want to start on 100% on the ventilator. I personally like to start a little less than 100% because if you set them at 100% and you leave them there for too long and you're maybe not paying close attention that perhaps the saturation is good and you should wean it, you really want to avoid denitrination atelectasis that can occur by keeping people on high levels of FiO2, specifically 190%. So I will like to start at 70, and this is something you titrate immediately if the patient's saturation is not improving. So let me just go over to a simulator, actually. So here is a lung simulator that is a ventilator. On the left here, you can see the graphics. We have volume in the top, flow in the center, and pressure at the bottom. Now notice I do not have a plateau set. And on my ventilator, I would have a peak pressure reading, and here you can see it's 32 centimeters of water. Now, I have no idea how much the lung is feeling. All I see is the peak pressure. So I have 450 mils set. This is an adult patient. It's 5.99 mils per kilogram of predicted body weight for this patient. I have respiratory rate set at 20. I have a flow set at 60 liters per minute, and you can see the resulting time, because it's 1 liter per second, I have 0.45, it's 450 mils. 0.45 seconds is what it takes to get this volume into the lungs, which is quite short. Now, of course, some modes allow you to do decelerating flow, but then you lose that ability to calculate resistance. Let me just change that back. Now, with that 0.45, I can now add a pause, 0.2 seconds, and I've just confirmed it. My IE ratio is going to change now that I've added the pause. I have a 1:3 IE ratio. And now you can see my ventilator's plateau pressure. So now I have peak minus plateau, and plateau minus peak is driving pressure. So I know my resistance is peak minus plateau divided by liters per second, which is 1, because this is 60 liters per minute. So my resistance is 12. And because my driving pressure is 10, 450 divided by 10, my 45. And if I look at the patient here, we have a resistance of 12 and a static compliance of 45. So I now have ongoing monitoring of respiratory mechanics. And of course, as it was already mentioned, when patients worsen, of course, you have to set alarms based on these parameters, specifically your peak airway pressure, because this will never change. Your volume will not change, your minute ventilation full, In terms of small changes may affect your peak because it's affecting your CO2. Why? Because your tidal volumes are changing. But with volume assist control, that doesn't happen. You do have to monitor this. Now, an example of increasing respiratory airway resistance. And what you'll see in a couple of breaths, you'll see the peak pressure goes up, and then my peak pressure is going to over here from 2, it's now up to 37. But notice the difference between my peak and my plateau is still 17. My resistance, I can still estimate my resistance or calculate it right there as 17, which is what I just changed it to. And my plateau remains the same and my pressure remains the same. It went up a little bit, and that's just because there's a little bit of auto peak, which is another maneuver that's helpful to do on a ventilator in terms of things that I measure. You can do an expiratory pause, and this will do a pause for 2 seconds and then stop, and it will tell me my total PEEP, which I'm guessing is going to be about 0.71 actually. So my total PEEP, very close, 10.7. So I've just done expiratory pause. I know total PEEP, driving pressure, plateau, and peak. So this is really the ultimate respiratory mechanics monitor. Let's just demo poor compliance now. I'll put the resistance back. And then we'll move on to another in just a moment. So let's get my peak pressure back down to 32. Okay, now let's change the compliance. And we should see the plateau pressure go up. There we go. Now, when your compliance gets worse, both your plateau and your peak will increase, but notice the difference is still 12 centimeters of water, and divided by 1, my resistance is still 12, but now my plateau has increased. So you can set your peak airway pressure alarm. It will tell you when there are resistance or compliance changes, because peak pressure will increase for both of those changes in condition. So let me set this back and then we'll go discuss pressure assist control. So just to give you an idea of what it looks like on a ventilator, so this is an example of a servo U ventilator. And what's interesting, the servo U, when you have the patient in volume assist control or any mode for that matter, plateau pressure, this value actually doesn't show on the screen at all unless you have set a pause. So when you set a pause of 0.2 seconds, this monitored value shows up all the time. And now what I have, if my flow is 60 liters per minute, which looks like it was here, the peak here is 70, so we're at 60 liters per minute of flow. I have 31 as my peak, 23 as my plateau, 8, so 8 centimeters of water per liters per second is my resistance. So I now know my airway resistance without doing any maneuvers on the ventilator. I also know that my plateau pressure minus my PEEP, if I know I need total PEEP, I know that my driving pressure is 13 centimeters of water. I can now monitor that in real. And if I take that 13 centimeters of water and I take my tidal volume by 13, actually get, this is actually showing, although it says dynamic compliance, when you use a ventilator and do a pause, it takes the last pressure it reads to calculate dynamic compliance, which is typically calculated by this if you don't have a pause. So this is actually static respiratory system compliance. And this is just another example of a different ventilator. This is an example of a dragger ventilator. Some ventilators, they may monitor plateau value, but sometimes it's showing you the last maneuver you did if you did a manual inspiratory pause. When you've set a pause like this, some ventilators you have to look up end inspiratory pressure and make sure you're monitoring that value. So in this patient, the peak pressure is 41 and the plateau pressure is 25. So pressure assist control, I won't go too much into the mode settings themselves. This was already covered, but again, you would adjust your pressure based on tidal volume. Your inspiratory time is simply the length of time that's maintained, and the rise time is just how quickly the ventilator reaches this pressure. So let's take a look over at the again and switch the patient to pressure assist control. I will take away the pause. So as I mentioned, ventilators do not have an inspiratory pause option for pressure assist control. So my inspiratory time is 20. I can check my IE ratio here, which is 1 to 2.75. Now, the one thing with a decelerating flow pattern is that it does take longer to get tidal volume into the patient. So this is similar tidal volume. This is off by about 16 mils from my previous example, but it's taking 0.8 seconds instead of I had 0.45 plus 0.2, so it was 0.65. It does take more time to get the volume in. And the issue, and as was already mentioned, the pressure, this will never change. Unless the patient, of course, is coughing, this can change, but in a passive patient, the pressure will not change. So if my resistance change, if it occurs, then you'll see in a few my tidal volume. And this is one of the concerns that was raised, that if a person gets a pneumothorax and the volume starts to drop, you may not have your alarm set sensitive enough to notice a change like this. So my volumes have dropped, my minute ventilation is going to drop, but my pressure keeps on trucking, no problem at all. So when you come to the bedside, you don't know if that was your problem or if the problem was your compliance. So let's go back to resistance here. Now you can do manual inspiratory pauses, but again, you can't calculate your own resistance. You have to, and not all ventilators have estimated resistance, and some of them estimate the expiratory resistance rather than the inspiratory resistance. So let me change the compliance now. And you'll see the same issue. The volume is 466. My volumes are going to drop. But again, no direct indication of what the problem is. So I don't know by looking at this. Now, if you are a very trained eye, you might tell that this is a steeper slope than it was before. So this is probably a compliance issue. When the slope goes slower, it's a resistance issue. But many ventilators have auto waveforms, so you may actually not notice that a subtle change like that occurred because it may auto scale and show you something nicer, even though it's changed. Now, one thing I didn't mention is of course, the trigger. Many ventilators will default now to a trigger. One opportunity to change to a pressure trigger in particular is if a patient has cardiac oscillations that are triggering the ventilator. They are much more sensitive for triggering a ventilator when you are on flow trigger, but when you do a pressure trigger of -1, even to between -1 and -2 centimeters of water, the cardiac oscillations will generally stop triggering the ventilator. So now let's get our patient breathing. But let's talk a little bit about, well, I've already gone through the settings here. Again, inspiratory times 0.7 to 0.1. Everything else is identical, but you would set a pressure control level to target your tidal volume. And just an example of what it would look like on a ventilator. Notice that the end inspiratory pressure now is reading the same. Why? Because you have a straight pressure reading there. Now, breath timing is important in all modes. And one of the reasons why I brought up the IE ratio a few times is because, again, inspiration is active. We set either a flow, which is a speed, or we set a time, and this becomes fixed for both modes. So for volume, the flow is fixed, and maybe your inspiratory pause is fixed. In pressure assist control, your time is fixed. But what is not fixed, of course, is the passive exhalation. So as you increase respiratory frequency, you then shorten your expiratory time. Okay, so you need to always reassess, is this sufficient time for exhalation? Because you may get into trouble as you increase the respiratory rate beyond the time sufficient for exhalation. It's important to notice that if this is what your waveform looks like, where your flow is not reaching baseline, you've gone past the point of actually helping yourself or helping your patient ventilate, and now you're just trapping gas, and it's now becoming refractory. The faster you go, you're not improving carbon dioxide clearance, and in fact, you could be making it worse. So with pressure support, there's no respiratory rate. You need to have a backup mode, which I think most people would understand. And most ventilators will default to just an assist control mode. But the I time is no longer controlled with seconds, but there is a way to control how long an inspiratory cycle lasts. And I think this sometimes goes unnoticed by many clinicians. They don't realize that in pressure support, we can control when the breath is terminated. So many ventilators hide this setting. You have to tap the screen 3 or 4 times to get to it. And I think that's actually an unfortunate issue because most people forget to try to adjust it. And of course, the rise time is just the speed at which the pressure is met. I'll demonstrate that in the next simulation because I missed it on the pressure control one. But here's a rise time here of 0.1. I'm just going to, before I show you pressure support, I'm going to speed this up. Actually, I'll slow it down to 0.2. And you'll see what it does. So you can see how rapidly this increases to the pressure here. And when I pause the screen here, you can see that this slope is now much slower. So you're just saying, take 0.2 seconds to get to this pressure. And the shorter it is, the faster it gets to that pressure. Okay, so let's change this back to 0.1. Most ventilators will default to 0.1 or 0.2. All right, so let's get the patient breathing. Now I'm going to start off with a patient with a very weak effort. And the reason why I want to show you weak effort, because I want to show you one of the issues with starting off on a pressure support. So how I set the ventilator on pressure support is I will always prefer to go low before I go high. So rather than starting at a high pressure support level, and for example, this patient will look like they are ventilating well. Let me just put the compliance back up to before. There we go. So once the compliance is back up, we'll see the tidal volumes will be acceptable. I'm going to slow this down so we can see more what's going on here. So tidal volumes are just over 6 ml per kilo, you can see. But this pink line represents patient effort. And if you see, the patient effort actually stops here. You actually see a little change in the flow deceleration here because it hasn't quite met the criteria, which I mentioned before, there's a cycling off criteria of 25%. So it waits until this point before it stops and cycles off. Now, it's obviously gone way too far. This patient has very weak effort, and we are over-assisting this patient, and we don't even realize it. We're happy with the tidal volume, pressure doesn't seem too high, but this patient is being over-assisted. And one way we can see if they're being over-assisted is there's a parameter on a vent, 0.1, and you can see it's 1.18, which is not low for a normal patient, but on an intubated patient, this or lower will indicate the patient does not have much drive. Now, this is one problem, but now add this low drive with someone with high resistance and watch what happens. And actually, I'm just going to give them normal compliance as well. So this might be someone like with COPD, for example. Notice how much longer the breath takes to cycle off. I haven't changed the cycle criteria. Again, resistance and compliance actually changes the slope of your flow. So now if you watch the patient going on, you now see this happen. This is an ineffective effort. Very common to see this, and very common in patients with COPD, for example. So they have a very weak effort. The vent takes way too long to cycle off, and when the patient's ready to take their next effort, the machine doesn't sense it. And actually adjusting the trigger sensitivity is the last thing you should be doing for this patient. In fact, what you should first try to do is decrease the amount of support you're giving. And then the second choice would be to change the cycle criteria, which I'll demonstrate in just a moment. Now, let's say I drop this pressure here to 10. Let's say my patient actually picks up their drive. I change the resistance or the compliance. I've just reduced this, and let's see if they pick up their drive. Let's look at the P0.1. Now my patient's drive is in a nicer range, so 2 to 4 is a nice range to be in, and you can see that they are no longer desynchronous, even though the resistance and the compliance hasn't changed. So try not to over-assist patients, but I'll show you the negative aspect. If you set this too high, 75% cycle off, see what happens to the breath, and then this will be it for the demo. See how quickly that cycles off? So this is 25%, this is 75, this is way too early, the patient is still inspiring. So that's how you would set pressure support. You need to pay attention to those things. So let's quickly go back to my final slide here. So considerations in volume assist control, the flow or the volume is constant. So you need to monitor plateau pressure and respiratory rate. You would set alarms for peak pressure. For pressure assist control, the pressure is constant, so you need to monitor tidal volume very closely and respiratory rate for when your patients start to, etc. Pressure support, start low pressure support and increase for tidal volume 6 to 8 mils per kilo. Monitor P0.1, 2 to 4 is a decent range. The percent cycle may need adjustments, especially in patients with COPD. And ineffective efforts occur typically due to over-assistance and weak efforts plus or minus high airway resistance. Thank you very much. I'm going to plug our blog, comv.ca, and there's some Twitter handles there.
Okay, that's great. Thank you very much, Tom. We've got time for a few questions, and maybe just for several people asking for a restate of the website that we had been referring to earlier. That's rtmaven.com that Tom Perino put together, and has lots of useful calculators and a few video demonstrations, as well as references to some of the papers that we've mentioned. Okay, I'm going to go straight into audience questions here, Tom. If the resistance was high, would driving pressure be less accurate?
So that's a really good question, because there are some patients in which, I'll give you an example of a type of patient. Cystic fibrosis patients that we will often see because we have a clinic at our hospital. So when they get sick enough to be intubated, they will come into our hospital as well. And when those patients are intubated, even when we set a pause, you don't typically see the pressure actually plateau when it comes down. So in patients with really high expiratory flow limitation, you may need to do a manual pause. The caution with that is that the longer you do pause, sometimes the less accurate your plateau pressure will be due to things as you may have a small leak that you're not aware of. And also you could have lung volume that may not reflect the pressure felt at end inspiration. So it's really hard to tell how long you should do a plateau. But yes, patients with really high expiratory flow limitation may not have an accurate plateau pressure if you're setting 0.2 to 0.3 seconds for that.
Great. Similarly, if a patient has flow starvation at your set rate of 60 liters per minute, do you increase the flow? Or do you just assess the patient's efforts and if high, increase sedation and paralysis? So
the challenge with higher flows is that most ventilators that use, for example, Fisher and Paykel circuits are very used in Canada, and I would say North America, maybe the world. Their limitation for flow and effective humidification to the patient is actually caps out about 60 liters per minute. So increasing the flow beyond that may make humidification, if you're using humidification, it may make it less optimal and could possibly dry out the airways. Having said that, when you change patients like that to pressure assist control, sometimes they may need more volume than what you are providing. And that's sometimes what I'll do if someone seems flow desynchronous. I will switch them to a pressure assist control, but immediately we'll look at tidal volume and monitor P0.1. I've had a couple of patients that I've seen over the years that wake up wanting a lot of volume. You give it to them. You're kind of worried about the volume, but then you look at P0.1 and it's greater than 6. You know that that patient's probably not doing themselves a service by having such a high drive. So trying to address the drive would be the most important thing at that point. And what mode you choose in the meantime, you just have to be cautious that flow is probably the worst thing for a patient experience. So I'd rather let the patient take the flow and the volume while we sort out and try to lock them in on a constant flow.
Great. Now you mentioned humidified circuits. Just while we're on that, there's been lots of chatter about what's the right way to ventilate COVID-19 patients when it comes to that. Do you want to comment briefly on your thoughts on using a heated humidifier versus a heat moisture exchanger in COVID patients?
There's a couple of issues. So HMEs can provide adequate humidification for the most part. When patients have high minute ventilation, I can sometimes not make it as effective. It's usually the tidal volume and minute ventilation combined that may affect the efficacy of it. The HME viral filters are sometimes less effective at humidification than the straight up HME filters. So these patients should have, if they are using an HME, you should have a viral filter there. Those ones are a little less effective at humidification. Having said that, many reports, we're hearing many reports of very thick tenacious secretions, and actually some warnings from people that were using HMEs, just that it can form casts and very thick secretions. So they recommend to be cautious if you're getting a lot of secretions to switch to something that's more optimal for humidification. The other issue is the dead space that an HME can add to it. So for example, if someone has high dead space and you have high minute ventilation, removing the tube on the inline suction catheter and an HME can typically increase alveolar ventilation by about 25 to 30% depending on the size of the HME. So all those things we personally are taking an approach of using heated circuits. Some of the concerns people have is if you have a disconnect, there may be fraying. I don't feel we have a lot of problems with circuits randomly coming apart. I think you just need your proning and unproning these patients particularly, but yeah, so those are the reasons why we choose the heated circuits.
Great. Now I'm seeing multiple questions about the issue about ineffective triggering and pressure support. Can you review again why over-support was the cause in the example that you had?
Yeah, so interestingly enough, probably the number one tweaked setting when someone can't trigger a ventilator, where they have ineffective efforts very clear between 2 delivered breaths, they have a missed trigger. Most people feel that adjusting the trigger is how they're going to fix it. And in fact, it's typically caused by over-support or something called delayed cycling. So we often forget that we control the cycling criteria of the ventilator, and giving high levels of support will cause a longer breath to be delivered. So unless we know the exact timing of the patient's breath, it's very easy for us to over-support, not necessarily with volume, but with time. Because how long it takes to get to that deceleration point at which you cycle off depends on resistance and compliance. So I would highly suggest people look for this in patients with high airway resistance or high compliance, so emphysema, COPD patients, asthma patients that are recovering. But it's generally caused by over-assistance of either volume or time. So just trying to adjust that. People, when you correct ineffective efforts in a patient who's missing every other breath, your respiratory rate on your ventilator will then double. Now, they were already breathing that fast, but all of a sudden you might upset people who think you've made the patient tachypnic now. But all you've done is unmask the tachypnea. Right.
And so this segues perfectly into the next question I want to address, which is what's the highest respiratory rate that you'll tolerate on pressure support? And related to this is we were actually just having a discussion before we started the webcast about the role of tachypnea alone in assessing a patient discomfort and work of breathing.
Yeah. I think, to be honest, a respiratory rate to me is not something that is necessarily concerning. If it's a high respiratory rate with high drive and high tidal volume, I think those 3 combined would be an issue. But in terms of what's my accepted respiratory rate, I've seen many patients with looking very comfortable breathing in the high 20s, even early 30s. These patients are more challenging to wean because we put a lot of stress in terms of their respiratory rate. But I probably would, and maybe you would want to chime in as well, but I think monitoring these patients, whether or not they are truly having a problem breathing, when someone has a weak breathe, they will typically breathe more shallow and more rapid, but do it quite comfortably and without a lot of distress. Maybe you want to say more about that, you. And I think high respiratory rates are they scare people. They should sometimes.
A big confounder is sedation, and sedation can change the respiratory pattern. So patients can breathe rapidly with very small efforts, or they can breathe slowly with large efforts. Probably the best data we have is that if somebody has a very low respiratory rate, then their effort is probably small. But aside from that, the respiratory rate is not that helpful to assess effort.
Yeah, absolutely. I think we have time for just 1 or 2 more questions. Why can't we do an inspiratory pause with a decelerating flow pattern?
You can. You have to do a manual pause, because the only way to get the ventilator, so in pressure assist control, there's not a specific setting for inspiratory pause in time. So in volume assist control, you can set a specific time, and we set between 0.2 and 0.3 seconds. But in pressure assist control, there's no actual setting for a pause. You would have to manually do it every time you want to do it, but you absolutely can. And that's how you would have to get an accurate measure of plateau. Having said that, if you measure plateau and it happens to be the same as what your peak pressure is, that means your flow is probably getting close enough to 0 during the deceleration that it does represent your plateau. It's just, we just have to be aware that the plateau in a passive patient is often lower than what you've set if your flow is not reaching 0. But you absolutely can do a pause. The only problem, if you want it in real time, breath by breath, you would have to increase your inspiratory time, sometimes beyond what's feasible for having a proper expiratory time.
Great. You and any other questions you want to field, or otherwise I have a feeling we might be at our time for drawing to a close. I've had, again, more it's a very popular website request, rtmaven.com is Tom's calculator website. And we've been recording this session, and we'll have all of these, the session and the slides up on our main course website, mechanicalventilation.ca. as well as links to it on criticalcarecanada.com.
Terrific.
Great, thank you.
So I think that draws our session to a close this evening, folks. I'd like to thank both of my fellow presenters, moderators, for some excellent presentations. I wish that we could see all of you who've been listening in person, and hopefully we'll be able to meet again sometime in the not too distant future. And until then, we'll keep going virtually. Highlight the fact that if you're just here as a refresher and actually want to get deeper into the guts of mechanical ventilation, we'll be having a full 2-day virtual interactive course in early June that we'd encourage interested parties to think about attending. And with that, I think we'll sign off and wish you a pleasant evening.
Okay, thank you.